Well then, let's get going. Want to thank everyone for coming to another one of our trauma talks. Today, we are very fortunate to have Jamie Sparling, who's coming to talk to us from Massachusetts General Hospital. She is now taken over a new role there as Director of Clinical Operations. We've been talking for, geez, almost 2 years now about trauma stuff since MGH is near and dear to my heart. And today she's here to talk about one of her passions, which is teamwork and communication. And with that, Jamie, I'll just give you the floor and it's yours.
Great. Well, thank you all so much for having me. Excited to share just a little bit of what we've been doing at MGH for the last few years. This is really informal, so please feel free to raise your hand, to come off mute and ask any questions as we go through, and look forward to some discussion. Also, special shout out to Justina Lupu, who's joining from MGH, who is now our new Senior Director overseeing trauma anesthesia. So welcome, Justina. Before we get started, I have a couple of disclosures, neither of which are relevant to this talk. And as an overview, I'm going to give you a little bit of background about the MGH Trauma Center, and then we'll review some of the literature on team training and performance in trauma. And then I want to highlight 4 interventions that we've rolled out at MGH on improving our trauma care through teamwork and communication, and we'll wrap up at the end, hopefully with about 5 or 10 minutes for questions. So by way of introduction, MGH is obviously a level 1 trauma center. We are the oldest and largest ACS verified level 1 center in all of New England, reflecting our long institutional history. Something else that's unique about us, we're also a level 1 pediatric trauma center, and we are the only institution that holds both of those certifications in the greater Boston area. We have more than 2,500 trauma admissions annually, and we're also very closely integrated with our burn centers. So MGH is an ABA adult and pediatric burn center, the Sumner Redstone Burn Center, and we also benefit from a really close affiliation with Shriners Hospital for Children, which is right across the street and is staffed by faculty in our department. Another unique thing, which is probably the reason we don't have even more trauma admissions, is that the greater Boston area is actually home to 6 other level 1 trauma centers, including one in our own department at Brigham and Women's Hospital. There's also 4 others, 3 in Boston and 1 outside Boston, that are adult centers, and then Boston Children's on the pediatric front. In terms of catchment area, so with this high density of level 1 trauma centers, there's some geographical nuances. So we do have a number of affiliate relationships with hospitals, both within MGB, that's Mass General Brigham, it's what used to be Partners, and outside of it. Because of the high density, I'd say usually the centers over in Longwood, so Beth Israel and Brigham, draw from Western Mass, and we tend to go up and down the coastline. We have quite a few admissions from Maine, from New Hampshire, and then down into the Cape, Martha's Vineyard, etc. And our trauma team at MGH is made up of 10 full-time trauma surgeons. So I've shown their pictures here. Um, some of them also operate either as generalists or just on the acute care front at some of our affiliate institutions, including Newton Wellesley and Salem Hospital, which is a level 3 center, but primarily at MGH. We're led by Ali Salim, who's, I don't know if you can see my cursor, but up in the top left here, he's the inaugural division chief across MGB, trauma surgery. And then the very well respected Dr. George Valmahos. Some people know him as the father of trauma surgery and acute care surgery. And he's just been a leader in terms of research and clinical certifications over the past many decades. Each year, in addition to these 10 trauma surgeons, we have 2 trauma and acute care fellows. And those of us in our department that are also intensivists are really lucky to get to work with them for 2 years. They always do the critical care year first and then in the OR second. And so we really benefit from those close relationships. We have a number of dedicated APPs in trauma surgery, including our program manager, Jess Ramaday, who's down here in the bottom right, um, and a highly committed multidisciplinary team. In true MGH fashion, we still meet weekly in person in a wood-paneled conference room and enjoy some hors d'oeuvres on Monday evenings together. And that includes our representatives from ortho trauma, Tom Lee over here on the right, Jean Kuo, our SICU director, um, Chris Stapleton from neurosurgery, and many others representing all of the affiliate disciplines. But I really love that we come together in person and are able to foster those relationships that makes us a better team. And we also have a really robust, dedicated trauma research lab and benefit from their involvement day to day as well. I next wanted to review just some of the general literature on team training and performance in trauma. So the first study I wanted to share with you really focuses on teamwork training and our performance in the trauma bay. So this was a single center pre-training, post-training intervention study at a single level one trauma center. And the intervention here was team steps training for 2 hours and a simulation exercise for 2 hours. And they evaluated the outcomes based on the Trauma Team Performance Observation Tool, or TPOT. And the outcomes that they reported that related to this were from their clinical data from their trauma registry over a 3-month period before and a 3-month period after the training. So a quick show of hands, who has heard of Team Steps before? Raise your hand, either on Zoom or Adriana, Jason has, some other folks have. Okay, and who's actually done the training before? A handful of folks? Okay, awesome. Um, so full disclosure, I never participated in Team Steps training, but in my current life, I teach our CBY, or clinical base year interns, Team Steps concepts and go through this training with them. So what Team Steps is a program that's developed by HRQ and the Department of Defense, and it utilizes evidence-based strategies to improve communication and team orientation through 4 teachable, learnable skills, which are in the middle of this pyramid over here. Those are leadership, communication, situation monitoring, and mutual support. And they align these skills against 3 domains of outcomes, which are listed here. Knowledge, i.e. creating a shared mental model, attitudes around mutual trust and team orientation, and then performance, which is measured against adaptability, accuracy, productivity, efficiency, and safety. And it focuses on the interplay between these different outcomes, and it highlights the interrelatedness of the patient care team, the patient themselves, the caregivers, and supportive roles. So with that in mind, that was the intervention that was delivered here. It was a 2-hour training based on this. And they measured the results against this TPOT tool, which is shown on the right. You'll notice that the 4 different groupings here relate to the domains of outcomes on the prior slide. And what's really exciting is that whenever they had this team-based intervention, they saw improvement across each of these different groups of domains. So leadership had 5 different scores, and the composite was increased, situation monitoring the same, mutual support and communication, as well as the overall score. And each of these you can see was highly statistically significant, as well as meaningful absolute increases. I know that you guys are excited about improvements in team performance, but I bet that you're really excited about improvement in clinical outcomes. And this study showed that after this intervention, they had reduction in the time to chest tube placement, the time to endotracheal intubation, and really importantly, in the time to transfer to the operating room, and by a pretty clinically meaningful interval of about 35 minutes. So I think that's pretty exciting. That's in the trauma bay, though. The next study is more broadly, so it's not just trauma, but it focuses on operating room performance. And it was a similar sort of design in that it was a pre-training, post-training intervention study at a single academic medical center. They also delivered team stats as the intervention, and they delivered it to all members of the perioperative team, including scrub techs, nurses, nurse anesthetists, anesthesiologists, and surgeons. And their outcomes were teamwork and communication scores. The operations director inside of me is excited about the first case on-time starts and turnover times. The clinical outcomes, including antibiotic administration, VTE prophylaxis, and beta blockers. And then importantly, in our patient-centered care, they looked at patient satisfaction. And in this study, they saw an improvement over years of implementation and the percentage of first case on time starts from around 70% to 95 or greater, and a corresponding reduction in their turnover time. They also saw improvement in terms of their surgical patient satisfaction scores from pre to post implementation. Similarly, they saw improvement over this time frame from 2006 to 2010 in terms of each of the SCLIP indicators that they measured here. And so in this single study, we saw not only improvements in teamwork and communication, but actually in clinical outcomes, as well as in some of the efficiency metrics that we track as a center. And then just to backtrack for 1 second, teamwork training has definitely been associated with reduced surgical mortality. So when you look at a large retrospective study of the VAs, where they essentially randomized VA centers to either undergo teamwork interventions versus not, and then they did propensity matching to look at outcomes of one versus the other. And they saw in the VAs where they had done the teamwork training, they had a 50% greater decline in mortality, perioperative mortality. However, the focus of this systematic review and meta-analysis was to look specifically at trauma team training. And in this, they reported on 9 studies, including that first one that I had shown you, and they were going to do a meta-analysis on 7 of those. They looked at different interventions, including simulation, didactic teaching, and other modalities. And none showed a statistically significant change in mortality, but there was a trend towards it with an odds ratio of 0.83. But again, really importantly, teamwork training for trauma was associated with really significant reductions in time to OR, where we can get life-saving interventions, and time to the initial CT scanner. So on the OR front, over a reduction of an hour and a half with highly statistical significance, as well as a reduction of about 17 or 18 minutes in time to the CT scanner. That's pretty exciting. Um, and then the last study that I'll draw your attention to, just to build on the concept of teams, is to highlight the actual relationships that are really important also. So specifically the study that's highlighted here focuses on surgical oncology. And they looked at this anesthesiologist and surgeon dyad, and they looked at 90-day major morbidity following esophagectomy, pancreatectomy, and hepatectomy. So I'm extrapolating from trauma again here, but I think it's exciting when you look at the number of procedures that dyad performed together over the prior 4 years. For each additional procedure that they did together, there was a 5% reduction in major morbidity. So I think that's pretty compelling. And if you think about surgeons and anesthesiologists that work together on a regular basis, monthly, bi-monthly, weekly, you can start to infer some pretty significant improvements in our patient care. And I think this just gives voice and some evidence to, I think, what all of us feel, and what Motaz is highlighted here on the right, that the way we embrace familiarity really does help us to deliver better patient care. So with this evidence in mind, the way we've approached our trauma care at MGH over the last 4 years has really rested on four different factors, or building on the work out of four different fields. The first is around team science, which is the study and the practice of how people from different disciplines work together effectively for shared goals, whether those goals are clinical care, research, QI, or others. In anesthesia, we think about examples of how we study and improve collaboration in the OR between anesthesiologists, surgeons, and nurses, and how we might come together towards improving efficiency goals or other quality improvement metrics. The second discipline that we've built upon is using simulation. And I'm sure everybody on this call has participated in simulation at one point in time. But really, what we mean is the use of realistic and controlled scenarios to teach, assess, and improve performance, decision making, and teamwork. In anesthesia, we use this to train our residents in crisis management. We practice OR to ICU handoffs, and we test new workflows out before we implement them. The third is human factors, which may be a new concept to some folks, but human factors is the science of understanding how people interact with systems, as well as how they interact with tools and their environments to optimize safety, performance, and usability. And so in anesthesia, we can think about this how we design intuitive anesthesia machines, how we streamline medication labeling, or how we improve the layout of the EMR. And then finally, ergonomics, not clicking through here, there's ergonomics, is really how we apply those human factors principles to design workspaces, as well as equipment and processes that fit our human abilities and our limitations. And so we can think about this in how we position monitors, medications and syringes, or airway equipment for ease of use, ways that we can reduce physical strain, or ways that we can prevent repetitive stress injuries. So taking together all four of these different disciplines has really led us to a couple of concrete examples of how we've worked together as a team to improve care. The first one of these is ED to OR handoffs. And so to step back for a moment, I think all of us can understand how in perioperative care, we participate in numerous diverse handoffs across different locations with variable participants, with some of the most common being from the OR to the PACU, back and forth to the ICU, or intraoperative handoffs, for instance, for a short break or at the end of somebody's shift. We know that handoffs in general, and specifically in perioperative medicine, can be error-prone, high-risk events, and that they are related to patient harm. They're also unique in anesthesia. If you think about handoffs in these different interfaces versus those that might occur at the end of the shift on a ward, we retain responsibility for the patient, up to and through a handoff. And so while a handoff's being delivered, we must be vigilant, we must be monitoring and treating the patient. So this creates increased vulnerability, but also potentially increased opportunity to identify improvements in patient care during these vulnerable times. And when I think about trauma patients, we think often about coming directly to the OR from the trauma bay. And we're going to come back to that. But we also have patients with prolonged hospitalizations, with frequent returns to the OR and to other procedural areas, with long, complex ICU stays, hospital stays, to and back forth from rehabs, for instance. And so they may be subject to a number of different transitions of care and the vulnerabilities that are associated with those. Handoffs have been such a focus for patient safety that members of our own department at MGH and others across anesthesia founded the Multi-Center Handoff Collaborative in 2017, which occurred after the Anesthesia Patient Safety Foundation, or APSF, conducted their annual Stolting Conference on perioperative handoffs. And this is an organization, actually includes some folks from WashU. Johanna Abraham is quite involved in leadership as well, if you know her. that really we're all aligned against the vision of eliminating patient harm across transitions in healthcare. And the mission of the MHC is really specific to perioperative transitions of care by promoting a culture that prioritizes interprofessional teamwork, facilitating creation and synthesis of evidence on perioperative handoffs and how to do so safely, supporting the implementation of best practices, fostering handoff education and training, and raising awareness to support our vision. And if this is something you're interested in more broadly, it's really easy to find just at handoffs.org. So please check that out. And so what we found at MGH is that over the last decade or so, we had focused on some of the more common anesthesia handoffs and really put a lot of effort into developing tools, cognitive aids, and training programs around how to do these well. So this is an example of our cognitive aid for OR to PACU handoffs, and we have a training program for every new clinician that comes into our department, whether through the residency, through an SRNA, or as a new CRNA or faculty member. They are all oriented, and we have these cognitive aids available as badge backers and posted in our PACU bays. We've also had a focus on handoffs to and from the ICU to the OR, where we kind of flip the card on either end, and really hone in on some of the elements that are more important for ICU care as opposed to just a standard elective anesthetic going to the PACU. And similarly, this is available on wallet cards and in our ICU bays as well, and we trained for this. And then finally, intraoperative handoffs have also been a focus, not just at MGH, but nationally. And this is an example of the intraoperative EPIC tool, uh, which was developed with MHC and members of EPIC that are also part of the collaborative. And so this is available to all the institutions that use EPIC as their EMR, and it brings together essential elements that should be highlighted during that transition of care, regardless of what role groups are involved. However, what we noticed is that there was really no standard approach to the highest security and most time-sensitive handoffs, i.e. those that proceed from the ED or the trauma bay directly to the OR. And it really surprised me that it wasn't just us at MGH that hadn't developed an approach to these highly vulnerable transitions. But when I do a literature search, there's not a single published report of ED to OR handoff tools. And I also couldn't find resources through this extensive network of handoff experts in the perioperative space through MHC. And at the same time as we were thinking about this problem, we had several patient safety events arise that in root cause analysis had stemmed from errors in communication at the time of the ED to OR handoff. And so this really created an opportunity for us. And so we embarked on this approach where really our goal was to create a consistent pathway to do this well, to safely transport patients from the ED to the OR for surgical and procedural emergencies. In doing so, first I'm going to show their pictures on the next slide, but really this work was led through partners across anesthesia and trauma surgery. So Dr. Ashwini Joshi, who's one of our new faculty members and a former chief resident, and Dr. Mike Duane, who's one of our trauma surgeons here at MGH. And so together we convened a team, not only with multidisciplinary members from trauma, but also bringing in other procedural and surgical subspecialties for the rarer times where they're bringing patients emergently. We worked together with colleagues on the ED front to map the current processes. And a really important learning was delineating how traumas are run in the ED and the trauma bay versus other types of emergent cases, where in traumas, they're really co-managed by the trauma surgery team with the ED team from the beginning. And so that transition can be a bit more seamless versus other surgical subspecialties are really coming in and owning the patient beginning when they arrive in the OR alongside the anesthesia team. And so we had to think about those a bit differently. We also work to establish norms in terms of transport roles and equipment that should be incorporated. with contingency of when those needed to be included. Iteratively, over the course of about a year, we aligned on content. First, for information to be transferred at the time of case booking, and secondly, for information to be transferred at the time of bedside handoff. And we talked about the conduct in terms of the roles, location, and other components to do this well. Similarly, we included this on a cognitive aid where the emphasis was really on timely transfer of the patient to the OR, elimination of extraneous information to allow this to be done in a quick fashion, as well as allowing everybody to reduce the cognitive load. And then we created cognitive aids and iterated on those in order to really hone down to what was most essential. We're currently in the phase of implementing this through educating clinicians and posting this in key locations at the kind of OR control desk and our trauma ORs and through badge backers as we've done with other types of handoffs. And in the future, we have a multidisciplinary simulation planned with faculty and staff from the anesthesia, trauma surgery, OR nursing, and ED sides to all come together and do this together as a team. This is an example of one of the cognitive aids. You'll notice that the mnemonic really emphasizes that timely transfer. So get to OR. The G is for getting ready. This is information that's transferred at the time of booking and is aligned against the A, B's, and C's. The T is for transport, where the emphasis is as soon as the OR is confirmed with the gray desk, that's our control desk, getting the patient there. And the O is for on arrival, where we hone in on any changes in the patient's status, transfusion, etc., that has occurred during transport, handing off blood products that have been brought with the patient, and then anything else has occurred and that hasn't been handed off. You'll notice there's a difference between the anesthesia cognitive aid and the surgical one, which is a little bit more streamlined, and just a different perspective, kind of being on the receiving end versus the giving end of that handoff. So we're really excited about that work. I think it's meeting not only a gap in tools for us at MGH, but also something that hasn't been done more broadly, and we're hopeful can be helpful to other centers as well. The second effort that we've undertaken is really on intraoperative communication. And so, over the last couple of years, we identified a number of circumstances where we have critically ill patients that are undergoing major operations that really rest on essential communication between our surgical, anesthesia, and nursing teams. And because each of our disciplines is really focused in on their role, sometimes people forget to communicate. And so we wanted to develop a protocol for how we do this well, and how we do it every time. What we developed was this intraoperative huddle. We aim to do this every hour. We aim to do it very briefly, lasting just 30 to 60 seconds total. And we always have the caveat that it can be deferred when clinically necessary, but we'll come back to it. And during this huddle, the surgeon updates on the operative plan, blood loss, any technical challenges, and communicates to our nursing staff additional instruments when necessary. From an anesthesia side, we update on the physiologic status, talking about resuscitation to date, how the patient's doing hemodynamically, checking in on temperature, etc. And then nursing can raise any nursing concerns, including availability of OR equipment or other things that have arisen. We thought a lot about how we should initiate this, and one of the insights that we drew is really the anesthesia team is the one that's there at the chart throughout the case. It's there at the head of the bed with us. And so we actually prompt this. I'll show you some tools for how we trigger this in order to decrease the cognitive load there. Up front, anytime we have an acute trauma, we mention this and we try and get it set from the start. But at any point when this is unanticipated, patient comes back to the OR, long ortho trauma case, etc., any member of the team can always invoke it. We've created a trauma macro in Epic in our EMR that can prompt reminders to do these. And then we have the anesthesia clinician kind of initiate this on an hourly basis. This is really easy to apply whenever we're setting up our record. And I'll show you in the next section, but we've aligned all of the medications with those that are in our trauma pharmacy tray so that we never have somebody having to search for medications to record them. It's just automatically popping up. So another thing just to decrease the cognitive load there. And then we have this hard stop timeout reminder that comes up every hour. And whenever you click on it, there's a little blurb that records that we've done this. And so whenever we have trauma sign out the next morning, it's one of the things that we debrief on, gather feedback from those involved in the case on how the communication went, was the trauma huddle implemented, and when it's not, it's sort of a QI follow-up for me and for the program manager on the trauma side. The third example of how we've been working to improve teamwork is through a simulation series. And so I don't know about at other institutions, but at our institution, there's a number of different procedural services that perform perk trachs. So trauma and ACS, I'd say do the large majority in our SICU. Thoracic surgery probably does the large majority in the cardiac SICU, and interventional pulmonology probably does most of those in the MICU population. So each has a little bit of a niche there. But of those, about 80% are performed bedside in the ICU, while those that are more complex, maybe they were difficult or risky airways, difficult anatomy, those come to the OR. And so we noticed as a consequence of this that the anesthesia providers in the OR actually had the least experience because 80% of the cases didn't come to the OR. And so they only saw these infrequently. We're part of a large department, and so they may have infrequently be assigned to those rooms and maybe only seeing a trach every couple of years. That's combined with the fact that it's actually the most challenging cases that come here with the highest risk of a lost airway or most challenging for reintubation should that be needed. And so these two factors combined with a lack of familiarity really led to some concerns for patient safety and a couple of near miss events. And so we wanted to create an intervention that would address, I think, these learning gaps, increase familiarity, and help us to work together as a team when those crisis events occurred. And so in this, we partnered with one of our trauma surgeons, Dr. John Parks, that's his back to us here, as well as a handful of attending anesthesiologists and a CRNA. And we were able to get funding through one of the educational grants at MGH. And we underwent formal simulation training, I think a total of 5 of us actually. And then each month we had a 90-minute simulation session with debriefs, pre and post assessment. And we used different combinations of clinicians there. So on the surgical side, Dr. Parks was always there kind of as the faculty preceptor. And then we had a senior resident actually lead sort of the didactic teaching there, while the intern was more or less the participant in the simulation exercise. And then we had on the anesthesia side, we would alternate between an attending anesthesiologist with a senior resident and junior resident, and then an attending anesthesiologist with a CRNA and an SRNA. And so we got all different learners involved there, and then also had more senior learners that were able to take on teaching and a leadership role. And through our pre-post assessment, we were able to identify improvements in knowledge of the major procedural steps of a perk trach. And they improved on their ability to place the steps in the correct order, as well as in identifying absolute contraindications, which were, really our effort to get at some of the outcomes associated there. So we're excited about these findings, but really more excited about coming together as a team towards this shared effort. Um, there were even some, I think, unanticipated opportunities that were identified here. So there were some latent safety threats that were identified through how our anesthesia techs were handling the bronchoscopes after simulation exercises that helped us to avoid issues with sterility for future patients. That was an important learning. We also were able to teach our surgical colleagues that are doing 80% of their trachs in the ICU without necessarily an anesthesiologist involved, what the difficult airway algorithm was and when they should call us, what equipment they should have available. So there's great learning, not only what was captured through these metrics, but also in the really rich debriefs that we had there. And then the last intervention that I wanted to mention here was just on the infrastructure side. And I think about this going back to human factors and ergonomics. So, how can we make safe, team-oriented trauma care really simple or as simple as it can be, and reduce the cognitive load for our clinicians? And I'm looking at the participants here as hopeful that Dr. Matthew Abadir, who is really the mastermind behind this, would get to join. But you guys should all know that he deserves the credit here. And this really focuses on our crunch room setup. So I don't know what terminology you all use. Crunch room is that OR that we have ready to go during off hours when our staffing is lower, that can accept a trauma on a moment's notice. We have everything ready to be able to care for a patient. Um, at MGH, despite the large number of trauma admissions, only so many of them come acutely to the OR. And we have a large faculty. We have a large main OR call pool. And so the effect of that is that we decrease the frequency of traumas that any particular anesthesiologist is seeing. We are not as lucky to have a dedicated trauma anesthesia call pool as some other centers. Whenever these events occur, we can witness communication breakdown, tunnel vision, difficulty with prioritization, which is just a known consequence of that high cognitive load, and this sense of just what am I missing? Like, what's going on here? And so, in addition to addressing communication through the previous three interventions that I reviewed, really wanted to make an ergonomic solution that would really take the guesswork and take a lot of the extraneous elements out of the cognitive load for clinicians at the time of an acute trauma. And so Matt, whose picture is shown here, he really laid this out in a really very straightforward and streamlined approach. This is what's given to our anesthesia techs, and they have a checklist. We know how powerful checklists are of where each element goes in the trauma crunch room, what needs to be identified where. And the same thing happens whether it's on the equipment side, so a Belmont, we call this the blood mobile, which is an extra place to chart blood products, the glide scope, the ultrasound. We've standardized even just what vasopressors go on which pumps. They're pre-labeled in advance. And then the trauma tray, pharmacy tray that I mentioned before, which aligns one-to-one with what comes up into Epic. So there's none of this searching, none of this guesswork. You can not even have to think about it, is the hope here. And through this, so Matt created these bins where if you know the patient's coming with an endotracheal tube, that's great. You don't even have to open that bin. It can just stay clean. It can stay in the cart and you don't have to deal with it. And then, depending on what access they come from the ED, et cetera, if there's an A line or not, really taking any extraneous elements out of the picture. We've standardized where all the monitors are, things like our defibrillator pad, etc., suction, so that whenever you come into this room, you've just heard about a trauma that's coming, everybody knows exactly what to expect. And he's done really great education with our residents, which are at the core of our overnight call team, bringing them up to speed, not only on setting this up, but going through simulation with them on their pre-call days. And he's been very dedicated in actually rolling this out. So every night at 5 o'clock, Matt Abadir is there, and he's making sure that this is in an appropriate room, that it's done correctly, and that we can all be reassured that we're ready to care for the sickest trauma patient. So, just to wrap up, um, really, I think everybody on this call knows that trauma care demands our precision under high pressure, where we care for some of the sickest and most time-critical patients. And the decisions that we make in every second of those is important for patient outcomes. We know in trauma, as in other areas, that communication and teamwork are absolutely essential to high quality care. And so, using those principles at MGH, we've been focused on safer handoffs, stronger communication, and really tight-knit teams to build structured opportunities to connect during the case, practicing teamwork using simulation and other methods, and preparing for whenever traumas come in. And then really thinking about those underlying factors through human factors and ergonomics that drive our approach so that we can design systems to simplify tasks, reduce our cognitive load, automate what can be automated, and help us all to focus in on the patient. So that's what I have to share. There's some fun photos of our amazing trauma team, which I'm just absolutely privileged to be a part of. And it's been really one of the greatest parts of my career so far. Feel very privileged to work with each of these individuals and to speak with all of you tonight. Thank you.
Well, thank you so much, Jamie. It's great to hear about what's going on back at Mass General. I know we have a variety of places represented in the attendance today. And so I think this is really useful. Just so it's always useful to hear what other places are doing. And I know just looking at the chat, I think a lot of these issues are shared amongst all of these institutions. Raj Nathwani he's out at Harborview in Seattle. He was requesting if you have any of those handout forms, if you'd be willing to share them. And we could absolutely distribute them if that's something you're okay with. Anyone else have any questions or comments at this point for Jamie?
Jamie, can I just ask you one other question? Because I know Justin and I have discussed this in the past. Sorry, it's Raj Nathwani from Harborview again. How do you streamline the numbers of attendings who are actually managing the trauma? We find it very difficult. We've got a pool of about 40 attendings, which means maintaining that relationship with your trauma surgeons, especially at night time, is very difficult. And we're just wondering how you manage your rotas to really keep a tight-knit group of anesthesia attendings managing your traumas.
Yeah, that's a great question, and I think one that we've gone back and forth on. I think you guys are probably at a better place than we are, to be honest. We have a large department just on the MGH side, excluding Brigham, over 150 faculty. Some of those are researchers that might be doing just a limited amount of time in the OR, but still taking call. Fortunately, those are spread across many different disciplines, and so there's probably on the order of 30 to 35 faculty taking main OR call for any given month. So that helps part of it. I think we do a much better job staffing our trauma ORs during the day. So there's a dedicated group that really are interested in trauma. Both we staff trauma and acute care surgery separately from our ortho trauma, but I think on both fronts we have a dedicated group, and frequently they're those of us that are trauma or are anesthesia intensivists. So there's an effort to staff us into the trauma and the burns ORs specifically. And then I think what we're limited by and structurally right now, we hope to by our teamwork training, simulation exercises to overcome some of the limitations that we have with being a larger group. But I think that there's definitely challenges associated, even by bringing people up to speed, both through education and some of the teamwork interventions that we've done here. Um, but by standardizing the crunch room, standardizing the handoff, standardizing the Epic tools that we're using, and training people up on those, we're hoping to work towards overcoming some of the challenges with the lack of familiarity and the reduced frequency with which we see these.
Yeah, I'll just comment. I saw that paper you showed at the beginning with the familiarity between the surgical team and the anesthesia team, and it's funny because one of our orthopedic surgeons shared that with me in the last few months as well, saying, "Hey, can we use this to kind of push for a little bit more exclusivity in terms of our team and really get us working together on a much more consistent basis?" Because we have it where we cover trauma 5 days a week, and there's still 2 days a week where the main OR general call pool covers. And so that really limits our ability to get that familiarity because now we're getting a call team that's seeing these cases even less frequently. And makes it all the more difficult. But yeah, Raj and I talk about this a lot because we both trying to find solutions here.
Yeah. I do think I don't know what your setup is like, but working together on the SICU front as well. The way we staff our SICU is generally with one trauma surgeon intensivist and one anesthesia intensivist, depending on the time of the month and the time of the day, et cetera. But even overnight calls, often that intensivist will pop into the traumas and be prepared to receive them in the SICU, of course, be responding if there's airway issues in the ED. So I think having that continuity and having those folks really be a heavy presence in terms of the daytime trauma coverage can be quite helpful with number one, strengthening the relationships that we have, but number two, kind of stepping in and being an intermediary between our anesthesia colleagues that do less trauma and the trauma surgeons that are used to seeing us.
Now, Jamie, you guys, I'm sure enough. I think we've talked about nothing's changed where you guys do not go down to the ED and have any role in the ED for traumas when they come in. Is that correct?
Generally, no, unless there's an airway intervention that we need to be involved in.
So,
Um,
with the simulations, I'm sorry, I missed it. Is the ED involved in those simulations?
the perk trach one that I shared, no. The handoff simulation, and it's kind of, for rollout in the next 6 months, we hope. They've been in lockstep on developing the tools as we brought them along, and we're rolling those out now. But what we envision is to have a simulation with ED providers and nurses, bringing the patient to the OR and kind of walking through the first step of the handoff, which is the get ready. That's the phone call case booking. And then the T is the transport, safe transport as patients. Things where we are avoiding the case where the patient, arrives in unrecognized PA arrest, and doing the at the bedside. So get to OR, so the out the bedside handoff there is what we envision to do those three elements all together with ED, trauma, anesthesia, and nursing.
And just looking at the chat, Tony DeLuvia, one of our trauma RNs, who actually leads our trauma video review, was asking about if you guys do any video review or what the review process is for cases. It sounds like you guys meet on a very regular basis, where, I mean, we have a monthly meeting, you guys meet weekly as a group. But how often are you reviewing cases, debriefing, resuscitations, things like that? And who's involved?
Yeah, that's every case. So usually that happens at handoff rounds with trauma in the morning, and that's just an informal debrief. How did communication go? What are the opportunities for improvement? Things that we need to follow up on, and then that's brought to the weekly trauma M&M that all of the multidisciplinary representatives participate in. And typically, if there's any concerns, I have a heads up that I can kind of reach out to the anesthesia team involved, answer questions, figure out if it was an error in charting blood products or did we truly give that unbalance of a resuscitation or that much crystalloid, or was the patient really that cold? So usually have a heads up where we can explore that a bit in advance, but every single case is debriefed. Specifically in terms of video review process, I'm not aware. In my since 2020, I've been a part of the trauma team. I haven't been a part of any video reviews, but we do talk about communication and teamwork in the trauma bay, just as much as we talk about it in the OR. And the members of the ED, so our ED nursing colleagues and physician colleagues, attend those weekly M&Ms as well. And that has prompted maybe a similar effort. Uh, I think because of the way our traumas are co-managed in the trauma bay, there was a specific effort around defining roles and responsibilities for the ED versus trauma surgery resident and trainee teams. And so, depending on the day of the week, they alternate. This team does A, B, and C, and this team does X, Y, and Z. And there's physical locations outlined for where they stand relative to different parts of the room, different parts of the bed, who's running it alongside the attending trauma surgeon. Is it the ED senior or the trauma surgery senior? And so I think I focused on our efforts on the anesthesia front, but I think similar efforts have been underway with our ED partners.
You mentioned this video, or I'm sorry, not video, but this handoff in the morning. Are you guys as anesthesia part of that as well? And who's with that?
Mostly that's internal to the trauma surgery team. I'll tell you that when I'm running the board, which is twice a week, I like to poke my head in because I want to know what they have at the top of the add-on list and what the acuity is and how I get that patient to the OR sooner rather than later. But it's not formalized that there's an anesthesia role for that, at least in the current state.
Kathy, I see your hand up selfishly just to get this on the record. How many rooms do you cover when you run the board?
Oh, we do not. No.
Oh, thank you. I just wanted that recorded. All right,
Yeah.
Kathy, you have your hand up.
Yep, that was an absolutely great talk. But I was wondering if at each for the group, I'm actually double trained in transfusion medicine, as I think Justin was saying. But I was wondering if you guys would have any interest, or if you think there is space in all of your, reciprocal relationships to include the blood bank. Actually, you mentioned getting a handoff on blood bank products, blood products that come up from the ED. But actually, every time you pick up a component, you're doing a handoff. And when the blood bank requests a sample to go back down to the blood bank in the middle of the case, that's actually also handoff. It's a little bit different than just sending a stat blood gas or something like that. So we have a close relationship with the senior people in the national blood banking community, actually, and we're very interested in doing some education. So do you think that Teams modules, that training would work in bilateral training with the blood bank stuff?
In the team steps, absolutely. I'm sure that there's elements that you could pull from that. And if you're interested, the AHRQ website has free, publicly available resources there and a curriculum. Um, in terms of the communication with the blood bank, I think that's a really excellent point. And uh, Justin knows this, but until a few years ago, MGH didn't have an MTP. Like we had emergency release blood, but we did not have an MTP.
Right.
And so, I think through that rollout, one of the lessons was really on communication preemptively with the blood bank when the patient's changing location. Because now that we have an MTP, the blood is going to keep going to where the blood bank thinks the patient is. And so that's like a huge utilization of resources on the blood bank side. And then it creates a huge patient safety hazard if the blood is going somewhere that the patient is not. And so that was something that was on our handoff tool, something that we really drew out in, I think, bold, all capital letters, call the blood bank to let them know the patient's moved. That stuff is not reliable and epic in real time. I think the other thing in terms of how our MTP is structured, if they have not received a type-in screen, then we really receive no FFP after the second cooler, and so we have a very strong incentive to get that to them ASAP. And so we do have frequent real-time communications with our blood bank are on that front. And then one of the steps that we've done to facilitate that is we have Voceras. Do you guys have Voceras? The little walkie-talkies?
No of them.
No.
We have. I know at WashU at least we just have iPhones.
Okay. We have our Voceras, which are hands-free. They have their own problems, but talking to the blood bank is not one of them. And so we can just say, call Legacy Blood Bank, and get through to the person on the other line and have these conversations in real time.
Thank you.
Ron Samet, who's division chief at Shock Trauma, is on. Has a couple questions in the chat. So he was bringing up specifically. I think he's still on if he wanted to speak for it, but I can at least introduce it. If you have multiple members of the anesthesia team, is there ways of controlling the communication between all members, or is it just more piecemeal?
Right.
So that's one, and then he also was talking about checklists, whether laminated versus electronic are appropriate. And Ron's on.
Yeah, I'm on. I'm just on the ward, so it's a little challenging. But one of the things that we sometimes struggle with is, it's sometimes pretty clear when there's anesthesia, surgery, nursing. There's sort of clear demarcations between different disciplines. But sometimes within the anesthesia group itself, when you have, an anesthesiologist, a fellow, a resident, more importantly, sometimes you have a seasoned CRNA and you have a faculty member, and then you have an SRNA, and the communication isn't always super, I guess, inclusive, so that it's all directly, even though we're all obviously one team, but it gets a little bit gray in terms of who's teaching who's conducting it, especially when there are different opinions from people that have been practicing for a long time.
Yeah, I can definitely relate to some of that. And thinking back to that perk trach sim that we did, I think the first time or two we had a mix of CRNA, SRNA learners with resident learners, and we learned from that experience to more thoughtfully group those learners so that we could have, more seasoned supervisees teaching the less seasoned folks. In terms of practically how it plays out in our ORs, I'd say for overnight off hours traumas, we don't have nurse anesthetists in house, and so they aren't frequently a part of the trauma care overnight. But we do have a whole resident team with its own hierarchy, and I find that the most streamlined way of communicating is between the attending and the most senior resident in the room, who is then in turn, I think, communicating with the more junior residents. That's kind of thought as part of the experience for the R1, as we call them. During the day, we definitely have CRNAs that staff our trauma ORs, and they'll frequently have an SRNA with them. And I find that our communication is usually with the CRNA and the team, and the attending, and then the CRNA does their own instruction to the SRNA in that case.
And then, Ron, you had a follow-up question as well about the checklists. Is there any movement towards electronic checklists?
Yeah, I think ultimately a lot of us sort of build these checklists. We hand out these forms. We have them in the OR and stuff like that. Even our mass transfusion protocol and some indications. But just human nature. Some people pay attention to them. Some people don't. Some people have them. Some people know where they are. New orientees may or may not sort of follow that, as opposed to a real process in which there's a sort of a digital checking off of that checklist and sort of tracking that.
Yeah, it reminded me a couple of years ago, they have an International Human Factors and Ergonomics Society, HFES, and they have a healthcare symposium every year. And so I talked about cognitive aids there. And I don't have the study in this slide deck, but there's a study out there that looks at digital versus manual or printed out cognitive aids. And in that particular study, I think it was during C-sections, they did show an improvement using the digital aid as opposed to a paper one. And I think it was for the reason that you voiced here is that it was kind of requisite to go through it to move on. Um, when we were thinking about designing like our intraoperative huddle reminders, we wanted it to be something where the reminder would be built in, the components that you were supposed to review during the huddle would be built in, but it wouldn't impede your clinical care in any way, shape, or form. So it might flash at you, but it's not going to prevent you from charting, from putting in an order, from doing what you needed to with the patient. And so we, I guess, have incorporated digital elements, but we haven't made them hard stops, even if we call it that, because we wanted to provide an opportunity to work around them if the clinical situation dictated it. So based on the one study that I'm aware of, digital did perform better than paper checklists. We certainly aren't there across the board, but I think that in designing some of these systems, it's one of the things that we've tried to incorporate, but doing so thoughtfully.
Thanks.
Any other questions or comments for Jamie? Well, thank you again, Jamie. That was a wonderful talk. I think everyone really appreciated hearing about all these aspects of teamwork and what we can do. And I know I'm coming out of it with some ideas. Thank you again, and look forward to talking to you more. And thank you all for attending. Look for our next invite. I'm trying to remember. I think we have at least one more before the end of the year, and we're already working on next year's schedule, and it's filling up. So a lot of more great talks coming up. So thank you all for joining us. Thank you again, Jamie.
Thanks. Thanks everybody for the discussion. Have a good night.